Good evening and welcome. I'm James Liu, and I'm a librarian at Stanford Health Library. Thank you for joining us for our talk. Don't miss a beat. What everyone needs to know about heart rhythm problems. It's my pleasure to introduce our speaker, Dr. Paul Wang. Dr. Wang will talk about how to recognize abnormal heart rhythms and what to do about them. He will share advances that are revolutionizing the field. Dr. Wang is the director of the Cardiac Arrhythmia Service and Cardiac Electrophysiology and professor of medicine and bioengineering by courtesy at Stanford University. Dr. Wang is an internationally recognized expert in heart rhythm problems. He co-invented new technologies that have been used in over 1 million patients. Throughout this talk, please enter any questions into the Q&A box at the bottom of your screen. And then at the end of the talk, Dr. Wang will try to answer as many of those as possible. There were also many questions that were pre-submitted by people who are dialing in tonight. And so we'll try to get to as many of those as well. Over to you, Dr. Wang.
Great. Thank you so much. I'm really delighted to talk to you all today about something dear to my heart, about heart rhythm problems. Don't miss a beat. Great. So we'll be talking about how do you make the diagnosis? How does one know that one has a heart rhythm problem? And we'll talk about some of the exciting things that we have, the new technologies we have. And we'll talk about some of the most common heart problems, how to detect them, what are the different kinds of considerations, what are the different kinds of treatments, both current and potentially in the future. So we all like to dream, and we like to think about how we might cure major problems that face the world today. And two of the most important problems that we face in all of heart disease are the problem of sudden cardiac deaths, which claims the lives of 6 million people worldwide annually. And also imagine that 30 million people could be cured of atrial fibrillation worldwide. So these are massive problems that I'd like to tell you more about today. It's my opinion that we will see a large number of breakthroughs in the next decade that will really come from the major new knowledge areas that we have that will allow us to conquer these very critical and important problems. So let's talk about terminology. What are heart rhythm problems? Something that we call arrhythmias, that is abnormal heart rhythms. We divide these into two categories. That is fast heart rhythms, sometimes called tachycardias, and slow heart rhythms, frequently called bradycardias. So we'll be referring to these as we talk about this in this talk. So what are some of the different symptoms of heart rhythm problems? So they might be palpitations. That is something that many people might describe as a racing heart sensation or a jumping sensation. It might be even something more dramatic, like dizziness or even loss of consciousness. Sometimes it will present as something like shortness of breath or even chest pain. And we may have symptoms that result in fatigue, lack of energy, or even exertional intolerance. So as you can see, a wide range of different possible symptoms that can be manifestations of heart rhythm problems. So why should we care about diagnosing these heart rhythm problems? First of all, as we've mentioned, they may cause important symptoms, symptoms that may interfere with our quality of life and what we want to accomplish and do each day. On the other hand, some heart rhythm problems may not cause symptoms, but in fact have association of risk. These might be risks of stroke, conditions such as atrial fibrillation that we'll talk about, or other heart rhythm problems such as ventricular tachycardia that may even lead to death. So these are some of the reasons we want to talk about these today, and I'm really excited about telling you more about them. So first, how do we make the diagnosis of a heart rhythm problem? And I think all of you are aware of what we call an electrocardiogram, an ECG, or an EKG. And as you see an example here, we could see that this is very easy to be able to record and document. And the beauty of this is that we have this is very plentifully available. We do not have an accessibility problem when it comes to making a heart rhythm diagnosis using electrocardiogram. We know how to do that. We know how to share this information. So really something that fundamentally is important in diagnosing heart rhythm problems. But one of the biggest challenges, having said that we can diagnose heart rhythm problems easily with an electrocardiogram, there is also the difficulty, and that is that many heart rhythm problems are infrequent and even what we call transient. That is, they're there one moment and gone the next. So presents a particularly great challenge for us in terms of capturing it. That is, doing an electrocardiogram at exactly the right instant. So that is the challenge of capturing transient arrhythmias. And so this is one of the areas where we've seen some of the greatest recent and future advances in terms of making the diagnosis. And so these are some of the devices I'm going to now tell you about. So our basic device is one that we can wear because we've already said the problem is that we may not be connected to an electrocardiogram machine, the big machine I showed you in the other picture, because that's a stationary form of technology. Instead, we're going to have the monitor go with us. And so this is the basic design of a type of system that is certainly advanced over the last several decades, but really fundamentally is very similar to what we had 20 years ago. And this allows you to record, but doesn't provide real-time analysis, et cetera, and other features that you'll see that we have now. This is actually a form of recording device that we use frequently. This was actually invented at Stanford. And so one of the functionalities that we have, it's really easy to use. It too is not real time, so we can't ask it, show me the electrocardiogram now, but it allows a much greater portability. It's a patch. It's like a very large Band-Aid. And that we can record not just for a few minutes, but for many days, really up to 2 weeks. So this kind of technology has really been a breakthrough in terms of ease of use and the ability to have the patient be able to record their heart rhythm for a longer period of time, and has really enabled discovery of many heart rhythm problems in many more people. But what are some of the other features that we all know about that we could say, well, these are going to be advances that are also important? And so these are, in fact, ones connected through Bluetooth technology. So they can communicate with our smart mobile phone technologies. They can even have some analytical capability. That is, they can even tell you if something is wrong, etc., and can send real-time these transmissions wirelessly. So a real advance in the functionality of what we can then achieve. So not only is it mobile, but gives us that immediacy of being able to send these right away rather than waiting for analysis to occur. And so what are the things that we think are both current and next generation? So the ability to have other wearable devices, shown here a watch, for example, that can have some kind of composite capabilities that allow us to record an electrocardiogram, a rhythm that can diagnose these various heart rhythm problems. So this is again another breakthrough that we have now that will really enable a lot of more diagnosis. And I'll show you some other examples. But further about this technology, so we've learned that we can that this is able to do so accurately, that there is the ability to make diagnostic recordings using this kind of technology. Furthermore, this has been the result of intensive study, a study done by some of my colleagues at Stanford. So, a very important study done at Stanford has been able to show that we can diagnose these heart rhythm problems in the real world. In fact, 400,000 people, one of the largest studies of its kind ever done, was able to use this kind of recording system, that is a watch, and be able to determine the heart rhythm problem accurately. So really, we've gone from a phase where these are new technology to now being able to show that they're actually useful and can be done in the real world in a large range of people. So what about other tools? Ones that actually do not record an electrocardiogram, but in fact have other sensors. And the most popular sensor is one that really looks at the ability to determine pulse and heart rate. So these do not have the diagnostic capabilities of electrocardiograms, but have the advantage that in various kinds of activity throughout our day, we can have devices that can notify us if there's a change in heart rate or even in many cases irregularity. So providing some analytics that might prompt us to do further investigation. So as you can see, we have an explosion of new kinds of devices that now are capable of making recordings that will lead to really the diagnosis of many, many more arrhythmias throughout the world. This is one of those futuristics by one of my colleagues, Professor Zenon Bao, who is using stretchable electronic technology to see if we can have a so-called electronic skin that can, in fact, record electrocardiograms. And we have a very exciting collaboration with her group. And so these are the kind of things that are being developed throughout the world and at Stanford, really that are forward-looking, that will certainly, I think, transform how we are able to diagnose patients in the future. This is another kind of device. It's not a wearable, but in fact, something that we call a handheld, where you can bring this around with you and then put your fingers on it and then get an electrocardiogram. So all of these in total, as you can tell, really give us a greater capability of being able to make these diagnoses. So back to, the different kinds of heart rhythm problems that we might see. So I've listed a number of these. These are the tachycardias or fast heart rhythms. And you can see they have a variety of different names. And we're going to walk through this and tell you a little bit about, what these all involve and how you might make the diagnosis and what importance they might have. So let's start with the first one, that is supraventricular tachycardia. These are fast, regular heart rhythms that commonly occur in young people. They're first usually diagnosed in the teens or in young adult age. And these are commonly things that we treat with either medications or even procedures that we call catheter ablation. So very common conditions that are throughout our populations and throughout the world, and for which there are very good ways to diagnose using the electrocardiographic monitors that we've talked about, and then very good treatments that we now have. Now let's turn to another kind of fast heart rhythm, and this is called ventricular tachycardia. These are also fast, typically regular rhythms, but these occur in patients that typically have heart problems, and we call impairments of heart pumping function. And in these patients, these in fact can be serious. So recognizing these becomes an important part of what we do, and in fact, we want to prevent any life-threatening consequences. So these patients may need certain treatments that might include medications or an implantable device called an implantable cardioverter defibrillator. So a variety of technologies, things that we certainly want to identify patients who are at risk to have these arrhythmias even before they have these, so they can be there to protect and prevent these life-threatening consequences. So how do we evaluate these patients that have not even had a heart rhythm problem yet? And so these are some of the different strategies that I'd like to tell you about. So first of all, we want to identify patients based on their heart function. That is, identify those people who have decreased heart function. We also want to inquire whether in the family history someone has died suddenly. And then we frequently will use different tests like genetic testing, which is now widely available, to evaluate further their potential risk or underlying condition. Also, as we mentioned to you already, we will typically use different monitors to capture a racing heart sensation and determine, is this something serious or not? And then to evaluate the overall heart for any abnormalities using tools such as ultrasound of the heart we call echocardiography. So as you can see, we have a general extensive approach to finding patients before they have a problem and identify them so they can get very accurate and successful treatment. So now let's move to the most common heart rhythm problem, and that is atrial fibrillation. So atrial fibrillation, as we'll mention to you, is really something that we describe as occurring in the upper chambers of the heart, the atria, and the electrical signal swirls around. I call it like a windstorm, just blowing from place to place within the upper chambers of the heart. As I mentioned, this is the most common heart rhythm problem. It is very common today in the United States and is associated with various risks, particularly that we'll talk about stroke and even death. As you see here in this graph, the rate of growth of atrial fibrillation has been spectacular, and we could expect this to continue to happen. More and more people will have atrial fibrillation as each decade progresses. This is a very early study, one that is a landmark study that says that we can identify patients with atrial fibrillation, and when we do so, we can in fact address and lessen the risk of stroke. And this was the original studies using a medication called warfarin. And now that has been replaced largely by other medications we call oral anticoagulants. I listed a number of them that are currently available. And the take-home message is this is one of the very important reasons to make the diagnosis of atrial fibrillation, because many patients who are at risk of having stroke can have stroke prevented very successfully, because now we know that we need to prescribe these medications we call anticoagulants. Sometimes people will call them blood thinners in order to prevent strokes very effectively. So a big message, one of the ones that I want you to remember. So educating patients about atrial fibrillation is very important, and we embarked on this approach to make this simple. And so you can go to afibguide.com and see this little cartoon video that we produced that will tell you about how to reduce the risk of stroke and atrial fibrillation. So as we talked about this is the most common heart rhythm problem. Sometimes we need to control atrial fibrillation using medicines and using a procedure called catheter ablation. And catheters are these plastic tubes that are inserted into the body and then deliver energy to kill those cells that are most responsible for atrial fibrillation. So an important recognition that patients have this kind of rhythm problem, and therefore identify what is the most appropriate treatment for those patients. There are exciting new technologies. This is the very latest. Really what we've seen in the last few months even. New energy sources that may improve outcomes in patients who are receiving catheter ablation. And this is called pulse field catheter ablation, and indeed may also make ablation safer. So really exciting. More stay tuned about the many future things that will be developed to make these techniques even better. I work directly with one of our heart surgeons, Dr. Anson Lee, and together we can perform catheter ablation not only from the inside, as we use with the catheters I mentioned, but Dr. Lee can come from outside the heart. And this is a very exciting collaboration that really is able to treat a large variety of patients as well. Now, this is a very important concept that we have so-called pillars of approaching atrial fibrillation management, and we're in the process of setting up a atrial fibrillation center of excellence to address many of these factors. We've already talked about stroke and how important it is to assess the risk and to treat it, and then to talk about how to optimize risk factors, and then how to reduce the burden of atrial fibrillation. So in talking about these risk factors, these are various things, conditions, various factors that we believe are important in increasing the likelihood of developing atrial fibrillation in the first place and impeding our management. So they go from high blood pressure, diabetes, metabolic syndrome, high lipids, obesity, sleep apnea, stress, smoking, and alcohol are many of the key ones that we feel we need to address in addition to addressing atrial fibrillation itself. So, as you know, all throughout medicine, there are many new treatments that are very effective that in fact we need to be able to use to treat patients with atrial fibrillation so that we're more and more successful. This is a study that looked at patients who had weight loss and showed that that alone could have a significant impact in how successful our treatment was with atrial fibrillation. There are many futuristic things that we'll be looking at, ways in which science will further advance treatment of all these different arrhythmias. And I'd like to tell you about some of the most exciting. So this is work done by our colleagues here, Professors Joseph Wu and Mark McCullough, who are using stem cells, which require just simply a sample of blood from the patient. And they can be re-engineered now using these amazing techniques to be able then produce heart cells that then can be studied to look at someone's ability to develop arrhythmias, either on it by itself or as a result of exposure to a certain kind of medication or drug. Pioneering work done throughout the world and done at Stanford. This is actually a story where this is the very first human report ever done in the world. It was done in Stanford using radiotherapy that's normally used for various tumors or other masses, but was able to treat without using catheters. This is a patient felt to be too high risk due to severe lung disease for catheter ablation and had a marked reduction in the rhythm we called ventricular tachycardia using radiotherapy and not requiring catheters. We expect that we'll gain much more information about doing this. We hope to do and are planning additional studies with a variety of arrhythmias using this kind of therapeutic approach. So what are my take-home message for today? First of all, as we talked about, we know that we can record these heart rhythm problems very accurately, and that's with the electrocardiogram. We've told you about a variety of heart rhythm monitors or watches that can be used to accurately record the heart rhythm problem. We need to evaluate patients because of their symptoms or their family history. We know, and it's important to stress the importance of anticoagulation, that is blood thinners, to reduce the risk of stroke and atrial fibrillation. And frequently, various procedures such as catheter ablation can be used to treat arrhythmias. And finally, addressing a variety of conditions like high blood pressure, diabetes, obesity, and other conditions may significantly decrease both atrial fibrillation and other arrhythmias. And with that, I'd like to thank you. Delighted to be here. Hopefully, that was instructive and answered many of your possible questions and thoughts about these conditions we call heart rhythm problems, so you don't miss a beat. Thank you very much.
Thank you, Dr. Wang. Looks like they have, I see four questions that were sent in the chat. The first one says, I have fast heart rhythm when I lie down at night. What is causing that?
Great. Well, that's a great question. I love that question. So it really speaks again to the fact that we need more information. But the good news is that has been already invented. That's the wearable monitor. It will allow us to very accurately diagnose what is happening. Is this a heart rhythm problem? Is this just normal heart rates that are just a bit faster? That will know really definitively, without much question, what is the heart rhythm? Do we need to do anything about it? So very confident that we can make a diagnosis. So you just need to go to your primary care physician. They could record order a monitor. You need to basically write in the diary what symptoms and press a button when you have them. So in fact, your doctors can go over with you, okay, when I have these symptoms, this is what's being recorded. And that's why it's so simple, but so effective.
Thank you. And then the next question is about a slide that showed uh, the big rise in atrial fibrillation over the years. And actually, I have the same question when I saw that slide. So the question is, how do you explain that rise?
Yes, it's great. It's a great question. And so we think it's due to many things, right? So as I mentioned, well, a few years ago, how did we diagnose atrial fibrillation? Well, you actually had to you had to go into a doctor's office and have an electrocardiogram. Well, as you know, that will only pick up a fraction of the atrial fibrillation. Much of atrial fibrillation is transient. It's not going to be there day after day in all patients. So just inventing these monitors that you can wear now and take around with you, as you can imagine, is going to lead to an explosion in diagnosis of atrial fibrillation. And that's in fact what we're seeing. It's very important to make the diagnosis because it might prevent a stroke. We know some patients that have a stroke that's unexplained that might be due to atrial fibrillation. So very important to make the diagnosis. The other factor is that we're living longer, right? With every decade, we've made great progress in terms of living longer, and atrial fibrillation, we know, is centered around ages 65 to 85. The majority of our patients are in that range. And so, as you know, both through the baby boomers and beyond, we've seen the overall age of our patients increase. They're living longer, more active lives. And so we're seeing an increase rate of atrial fibrillation based on the age of our population. And then additionally, we we are seeing many an increase in metabolic syndrome, obesity. Many of our patients, a significant proportion of our patients are in that category and have those issues. And so that may again contribute untreated or not completely treated high blood pressure. We know half the adult population in the United States has high blood pressure. Of that, half of those are not adequately controlled. Those things contribute to conditions over years and years, such as atrial fibrillation. So many of these can be preventable, but we know over time that, in fact, we can expect to see more and more atrial fibrillation being diagnosed. Thank you.
And the caller, I mean, the participant who asked about when she lies down at night, she gets the fast heart rhythm. She said also she been diagnosed, but they don't think it's dangerous. And what she's doing is she's taking a lot of magnesium. And when she does that, then the problem goes away, she said.
That's right. That's a great question. It's rather interesting. Magnesium has had a role in certain arrhythmias. It just doesn't treat all arrhythmias, unfortunately, and has some limitations in terms of its use. But indeed, We recognize that potential, benefit in some patients. Yes.
Mhm. Thank you. And is there a link between atrial fibrillation and stress?
Great question. Yes. So I didn't really talk about, what are some of the various other factors in terms of atrial fibrillation, both in terms of what we call triggering it. In other words, there are certain things that we think may not necessarily cause it per se. Someone has a tendency, but there are certain things that can be triggered, meaning if you're under a certain circumstances that might produce the atrial fibrillation at that time. So things like dehydration, for example, we don't think it causes atrial fibrillation, but for sure it can trigger it. Meaning if you have certain things that happen at the same time, sleep deprivations, uh, dehydration, other factors, extra stress might all come together and then trigger it, the atrial fibrillation. It might explain why at one point in time you might have it and it didn't happen at another point in time.
I see. So, if a person is otherwise healthy, no metabolic or weight problem, can they still have atrial fibrillation?
Oh yes, absolutely. Many of our patients, certainly most of my patients live in Northern California. We are generally a healthy lot, and exercise, etc. But as we mentioned, there are many factors, and indeed, simply as we get older, we're more likely to develop atrial fibrillation. So many of our patients don't necessarily have any of the various conditions I mentioned, but still go on to have atrial fibrillation.
Okay. And then this next question is about heart palpitation. This person says, I got it from my grandma, and I also passed it on to my son, and my son is really worried. Like, and so in this case, what should he do?
Yeah, it's great. In fact, I was just thinking of that and from the last question. And so we do know, just as many other parts of our bodies, et cetera, we know that there can be genetic relationships, right? So that certain aspects of our genetic makeup likely contribute to atrial fibrillation. Now, that's not all our patients. Many, I would say, frequently, we ask patients, anybody else have atrial fibrillation? And they really can't name anybody else. Other families, we know many people in their family. So there's a range to which we're both aware and can and potentially pinpoint that. Now, one area that particularly is of interest, and my colleague Dr. Marco Perez is an internet expert in this area, that people who are much younger who develop atrial fibrillation 30, 35 or less. We have people in their 20s that have atrial fibrillation. They're more likely, we believe, to have a genetic basis. And so we actually recommend that people do additional testing, have genetic testing. We do that, our group does that, and that can identify, in many cases, a certain tendency towards atrial fibrillation and other heart-related conditions.
Okay, thank you. And then this other question is about blood thinner medication. Are there options other than like taking it lifelong, the blood thinners? And in this case, the person is over 65 and he or she has had AFib twice already, and they were corrected with cardioversion.
Yeah,
So,
yeah, great. Yeah, great. It's a really key question. I think the biggest thing we try to emphasize is that anticoagulation still is the major treatment to reduce stroke. So for most people, we think anticoagulation, these medications, often called blood thinners, are the most effective treatments in reducing stroke. So for many people, yes, they likely will need to take this lifelong. There are some other strategies. One strategy is One can put a special device. It's a little, I call it a basket, but it's not a real basket. It's a little device that you can put into part of the upper chamber of the heart, the left atrium, called the left atrial appendage. And this is called a left atrial appendage occlusion device. And it's been shown to be, similar in terms of its effectiveness in reducing the risk of stroke as anticoagulants. And so for some people, certainly for patients that cannot take anticoagulation, this is really an ideal kind of approach. So there are other options that people are developing, and as I mentioned, many new technologies are being developed all the time to look at this. There are also interesting studies to address the question of, oh, are there people who can take anticoagulation intermittently? Now, I have to stress this is a study. We do not advocate this. We say that you need to take it all the time. In fact, you should not miss doses of anticoagulant. But there's a study going underway, including at Stanford. It's an international study called REACT-AF that my colleagues, including Dr. Perez and others, are involved in, and Dr. Perino. And it's called REACT-AF, and it's trying to look at whether taking anticoagulation only when you have atrial fibrillation is as good in reducing stroke as taking it all the time. So patients are randomized, half in taking in the medication, and the other half receive a watch, and when it signals that you have atrial fibrillation, that's when you take the anticoagulation. So that's not something we can do now. That's not approved because we don't have the answer. We don't know whether that's equal in terms of its safety. But in the future, in a few years, we will have the answer. So potentially in the future, we won't be saying, oh, you need to take it all the time. But now we do. We still say that you need to take the anticoagulant all the time and don't stop it.
Uh-huh. Thank you. And
Sure.
then the next question is about ablation, the differences between freezing and radio waves. And the question is, which one do you prefer?
Yes, great. So we're very fortunate, right? So we live in an era where we have much more knowledge. We have advances in science. That's why it's so important that we, support science in our society. And so there are these advances. And so we've seen, this progress greatly because several decades ago, there was no such thing as catheter ablation. The only option, which was very limited, was open heart surgery. And so very few people received that. So as soon as the field developed atrial fibrillation catheter ablation, more and more people were able to be treated and more successfully at lower and lower risk. And so we've seen generation after generation of different forms of technology that have developed. And the latest, as I described to you, was pulse field. Again, we're still waiting for studies to show, is it definitely better in terms of outcomes and risk? I think the early signs show that it may be, but indeed it's not been proven definitively yet. So more to come. This is an area where we're all very interested. We've been involved in a number of these studies here at Stanford. And so these are the kinds of, really studies that we need to conduct.
Okay, and then the next question is about pacemakers. What are the latest trends and what are the pros and cons between different types?
Yeah, great. Again, this is an amazing time to, be alive and to practice medicine because we're seeing an explosion of technology. Again, things that were really unthinkable, I'd say even 10 years ago. And so we have miniaturized pacemakers, pacemakers that are, smaller than a pen cap. I mean, we're talking about really amazing innovations that exist right now. We have pacemakers that can, improve the overall pumping function of the heart in some cases. They can help diagnose these different arrhythmias. So there's many, many different ways in which we're seeing major advances, and the advances continue every single day. And so that's really, one of the conversations you want to have with your heart doctor if you are told you need a pacemaker, that, what's the best one for me? Why should I pick one versus the other? And so ultimately that's an individualized decision because each one depends a lot on a certain characteristic. There is not one size fits all. And so that's the importance to really make sure that you have consideration of all the different aspects in terms of the choice.
The next question is, are there special considerations if the heart rhythm problems are due to structural defects in the heart?
Yes, oh, there are. And so, as I mentioned, there's a whole range, right? So, some heart rhythm problems, like atrial fibrillation, et cetera, are not immediately life-threatening, other than risk of stroke that we've talked about, are not. But there are other rhythm problems, such as ventricular tachycardia, that it absolutely can be. And so, diagnosing those and assessing the patient's risk is very important. So that's why we used various tests to assess what is the heart function, how impaired is it, are they at risk to have these serious arrhythmias, and so that's a big part of what we do as well. So it's very critical to determine, what is the risk? Is it, important given the structural abnormalities that you've mentioned?
The next question is about sinus rhythm. What is it, and is it considered normal?
Yes, exactly. So sinus rhythm is exactly normal rhythm. So the reason it's called that is the heart has its own pacemaker. We're all born with that. It's called the sinus node. So rhythms that originate from where it's supposed to come from is therefore called sinus rhythm because it's really coming from the sinus node. So absolutely, that's the standard. That's what we all are in if we're not in one of these arrhythmias. Yeah.
Okay. Next question is, what is the impact of left branch bundle block?
Mhm. Great. So these are, really fascinating advanced questions. So the heart, I describe to my patients is like a house. It's a two-story building. There's a top floor and a bottom floor. The sinus node is in the top floor, so the signal has to get from the top floor for the bottom. And so we have, just like our house has electrical wiring, so does the heart. It has specialized cells called conduction system cells that connect the upper chamber to the bottom chamber, the ventricles. So it has to go through this conduction system. That includes the AV node and what's called the His bundle and the bundle branches. So usually that's undisturbed. The signals go down without any problem at all. That's why we have very reliable conduction from the top to the bottom chamber. Sometimes, however, one of the branches, and so the conduction system is divided into two branches, a right bundle and a left bundle. One of them can have impairment of the conduction, and it could be right bundle branch block or left bundle branch block. The significance of left bundle branch block is that it's more likely to be associated with impairment of heart function. But I'd say the most important significance is that in some cases, over time, it can result in weakening of the heart muscle. And part of that's because it's less efficient in terms of contracting. One part of the heart contracts first, then the other part of contracts later because of the delay that is a block. It's like when you go down the highway and it says detour, well, you got to go a longer distance. It takes the signal longer. And that time delay is what results in the inefficiency. And so people have invented over the last couple of decades the ability to create a pacemaker that can pace two parts of the heart so that they're getting coordinated much better. So instead of one part of the heart contracting first and then the other second, it contracts together more evenly. And so that's one of the reasons we recognize left bundle branch block. For some patients, particularly those with impaired heart function, they should get this special pacemaker that can coordinate the heart function.
So the next question is about the difference between the atrial flutter and atrial fibrillation, and how are they treated differently?
Good, good. Yeah, great questions again. So atrial flutter is also a rhythm of the upper chambers, just like atrial fibrillation. So we often call them siblings, right? So they're both from the upper chambers. They're similar in that way. But just like our siblings are unique, they're unique in another way. And atrial flutters are, generally speaking, they take a specific path. It's like, oh, okay, I have the same route. I go to the grocery store every time. I take the same route over and over again. Whereas atrial fibrillation is literally somebody wandering around and suddenly they go from one place to the other. It's not a specific path. Whereas for atrial flutter, it is in a specific path. Now, there are some similar consequences, increased risk of stroke. Patients are typically on anticoagulants. There are other, treatments, medications, catheter ablation can be used too. So they have some similarities, but fundamentally there are differences in how the rhythm gets created.
Okay. This next person says she developed ventricular tachycardiac uh, after her menopause. And the question is HRT recommended for arrhythmias that develop from hormonal changes?
Okay, great. So first of all, there are many causes of ventricular tachycardia. The first one is really to determine, is there a structural abnormality? That's really one of the first things that we determine. And we typically rely on echocardiogram, the ultrasound of the heart, to see if there's impairment. Sometimes we'll do a very specialized test called a cardiac MRI to look for other abnormalities. So that's one of the key first points. In many cases, however, in some certainly, there's no evidence of any structural abnormalities. And there are a certain group of patients that have ventricular tachycardia that we think does not have the same risk of serious life-threatening consequence, but is influenced by other factors. Stress, as we've talked about, stimulants like caffeine, and then certainly hormonal influences. And so we've pretty clearly defined that there are influences, but I think it's too simplistic to say, yes, they should be treated with hormonal therapy. So that decision has to be very individualized to make sure that that is the correct path and doesn't cause harm.
The same person asked if she had just a few episodes while taking a beta blocker. Is that considered managed already, or should there be no episode at all?
Yeah, again, I think the first issue is, what is the underlying condition of the patient? Is there the structural abnormality? Has the patient had a thorough evaluation really to exclude other structural abnormalities? That's the first thing. It's hard to answer the question until you really know what the risk profile is, right? So if the patient's at high risk, one wants to make sure that they don't have really any episodes. If it's considered more benign, then it's much more symptomatic. And we can have that discussion with the patient. Well, how much do you want to tolerate? Is the medication causing more side effects than your symptoms of your tachycardia? So it becomes a much more individualized decision.
So the next question is early catheter ablation generally better for most AFib patients? And what are the cons?
Yeah, that's a great question. So the uh, there has been a lot of new data that have come out really very recently in the last couple years, 2 to 3 years. And so our whole approach has changed dramatically. I think in the past, the way we would approach it is, well, you're doing pretty well in medicines or you're not very symptomatic. It's pretty okay to postpone catheter ablation and get control of the rhythm overall. But there's more and more data to suggest that that should be done earlier and earlier, that we really shouldn't allow too much time to go by in terms of before we try to make sure that we have better control of the heart rhythm. That is, keep the person in normal rhythm. So I think that's been the dramatic change that has happened, so that many more patients are recommended to have catheter ablation as a result.
Next question is about acid reflux. Can it trigger AFib?
Sure, yes. So it turns out there are many probable mechanisms in which things like acid reflux, a variety of other gastrointestinal symptoms and conditions seem to trigger atrial fibrillation. And so we definitely recognize that that can be a very important trigger. And therefore, we really recommend to our patients that they get that treated very aggressively.
Okay. The next question is about a particular drug, in your opinion, to control AFib. and a drug named, I'm not sure how to pronounce it, but it's the drug that starts with the letter D as in David, DOFE.
Oh,
No,
dofetilide. Okay,
yes.
sure. Yeah. So what's important is that what we're talking about medications that are used to try to keep the rhythm in normal rhythm. We call those antiarrhythmic drugs. So that's what we're trying to achieve. That is normal rhythm. And so that's the strategy called rhythm control, meaning we want to keep the rhythm normal. And there are six drugs that are used. And we choose them based on a variety of criteria. Some patients have normal hearts. They don't have any artery problems of the heart, and they probably can get any one of those, a number of them. Other patients may have various heart conditions, and they can't take these other certain medications. And then some patients are treated with a medication because they've tried several others before and they haven't worked adequately. And so that's how they get to this medication. So each medication has its pros and cons, its stage of when we use them, a variety of things like that. So for each medication, one needs to have all those considerations and what are the pros and cons of that medication. Some side effects, some other risk profiles, they all have to be considered.
Next question says, if you feel, or if I feel that I'm having a AFib right now, is there anything that I should do to stop it at that particular moment?
Great question. Yeah. So so I would say we do not have a uniform way to stop atrial fibrillation each episode. I know patients that have some kind of strategy that they do, and they're very effective. But that's, I think, a small number of patients. Most people really cannot find a way to stop it very effectively. That's the general rule, even though some people, I believe, totally can do it. And so it really comes down to severity of symptoms, whether they have other heart problems, et cetera. And that's how we advise people. If the rhythm is tolerable, not too rapid particularly, many patients just ride it out. They know it's going to stop within a certain number of hours. They go rest, et cetera. And so then they know that that's going to pass. For other patients, they know once it starts, it's never going to pass. And so then they need to figure out a strategy, contact, us or their doctor and figure out what do they need to do? Do they need a conversion with an electrical shock to the chest called cardioversion or not? So each person is going to get their own, instructions based on how well the atrial fibrillation is tolerated. For some patients, they can't tolerate it very much at all. They're going to have to call 911 because they're dizzy, their blood pressure drops, they're very short of breath. They just won't tolerate it even for a few minutes. So that is a much more acute situation. So you can see it's widely variable. That is one reason we use something called rate control. That is, patients can be on medicines that just slow the heart rate in atrial fibrillation. So it's not nearly as fast. That alone can make atrial fibrillation much more tolerable. Simply getting the rate from 140 down to 85 makes a world of difference to most patients. And so that aspect of controlling the rate better, being on these medications can make just the quality of life so much better in terms of how they react to the atrial fibrillation.
Next question is about anti-obesity drugs. They're so commonly prescribed nowadays. Are there any conflicts between those drugs and AFib treatments?
Sure, there always the potential for conflicts in terms of various drugs we take, et cetera. But these are becoming increasingly part of what are used for many patients with all kinds of conditions, including atrial fibrillation, because of the benefits overall to the body. Now, we don't have a lot of data to show that the exact effect on atrial fibrillation yet. I know we will in the future. But again, I think because these different medications do positively affect the risk factors, I think most of us are pretty optimistic that this may improve how atrial fibrillation develops and can be treated.
And next question is, what is the best treatment for atrial flutter for somebody who's in their 80s?
Yeah, so again, that's an individual discussion because for some patients, it may have very little consequence. That is, they as long as they're on anticoagulants to prevent stroke. Some people don't need much treatment, right? They may be transient. They may, really not be symptomatic. So that again, that's an individualized decision as to what to do. Other patients probably will be treated with medications or catheter ablation.
Next question is, what about slow palpitations that last from 1 to 2 days?
Sure. So again, we need to know what rhythm that is, right? That could be atrial fibrillation. It could be something else. And so we're going to want to know, should the patient be on an anticoagulant? What kinds of treatment should they have? Should they be on medication? Should they get catheter ablation? So all those factors are important. Even though the rate is relatively slow, they still may need those things.
Okay. Next question is, can the implantation of a stent cause AFib?
Sure. So, we never say never, right? Because atrial fibrillation reflects what's going on, overall for the body. I think there's many things that can trigger atrial fibrillation, and so we don't say, oh, that's never going to happen. In fact, I'd say almost anything could trigger atrial fibrillation. So it's so common that it doesn't take a lot to basically precipitate an episode.
Okay. This person probably has a multiple ablation already for AFib, and so he or she is asking, what comes next? I guess they don't work.
Sure, sure. Well, I mean, again, we recommend, what we would do is to take a look overall, what has been done, what possibly could we offer in addition. And so we don't say, oh, that for another ablation is not possible. We look to see. We're very candid with the patient as to what their success is going to be. We don't say, oh, we'll promise you we could get you to normal rhythm. Maybe, maybe not. But again, it's going to be up to the patient what they want to do as well. We could sometimes prescribe different medicines, even ones that have been tried before, may work now. There are a variety of things like that. So there are many different, possibilities. I mentioned some of our patients will go for the hybrid surgical catheter ablation that work with my colleague, Dr. Anson Lee, the heart surgeon. So there are even other strategies. And then additionally, there are a small number of patients that receive a pacemaker and do what's called an AV junction ablation. That is, get rid of conduction from the top to the bottom. So it's not too fast. They still remain in atrial fibrillation, but no longer as fast. That's not commonly done, but very specifically reserved to patients that have extremely fast rates that can't be controlled.
Next question is, are the newer anticoagulants more effective than warfarin? And what are the pros and cons?
Yes, exactly. Yeah. So I think the field believes, yes, the new anticoagulants are better and safer. So the field was able to make a pretty big advance. It's also easier in terms of quality of life. They don't have to get checked all the time. There aren't the same food-drug interactions. And so overall, the new anticoagulants are really a significant advance for everyone.
Next question is, what can you recommend to somebody who cannot tolerate blood pressure's medication?
Yeah, exactly. So for arrhythmias like atrial fibrillation, that's when we go to catheter ablation or other specific medications. So they may not tolerate them, and so those patients generally do get the catheter ablation.
Next question is about calcium scan. Does calcium scan score of 47 create an arrhythmia?
Oh, is the calcium score related to arrhythmias?
Yeah.
That's an excellent question. I think it's understudied. We don't know. Again, I think we try not to say, oh, nothing is related because the whole body is related to each other. So we just don't know, right? I think the fact that we can't say definitively it's related may be because we haven't studied it adequately. So we don't really know.
Okay. And this question goes back to the acid reflux, whether it could cause AFib. The person says, can it cause ventricular tachycardia as well?
Yeah, it's a good question. So I'd say overwhelmingly we see much more of the atrial arrhythmias, partly because they're much more common, I think. So again, we rarely say it cannot do that. I think, we, you know, I think we have enough experience that we know so many things trigger different heart rhythm problems. As you can see, that's the theme, right? Triggers of arrhythmias are very common and pretty widespread. So I would not be surprised at all if a patient told me, "Oh, under these circumstances, that's when I get ventricular arrhythmias." I would totally believe them. It just doesn't take a lot for many people to trigger. And so for one person, it's one trigger. For another person, it's a different trigger. So even though it might not be the highest list, if you ask a doctor, "Oh, is this a common trigger?" They might say no. But just because it's not a common one doesn't mean it's not true for that individual person.
Okay, I just looked at the clock and we're at 8 o'clock. Are you okay, Dr. Wang, to answer a few more questions?
Sure. And then we probably should, close up after that. But
Sure.
yes,
Okay.
sure.
And next question is about PVCs. Is it still considered reasonable to leave PVC untreated and allow the patient to just adapt?
Sure. Yeah, so PVCs are premature ventricular beats, that is from the lower chamber. They're pretty common. Many people have them. Some people are extremely bothered by them. It's a quality of life issue. So for those people, we really try to find a strategy. Generally, it's medications or catheter ablation. Those are the options that we have. You can try other things, stress management, etc., but generally that's what you're going to do. The biggest issue is that when they get very frequent, in the 20+% range typically, that they can start to impair heart function and weaken it. And so we don't want that to happen. So we watch the heart function carefully and see whether, in fact, that we see evidence that the heart function is becoming impaired. And that would be one of the reasons we would step in and want to take care of it. Um, I think some cardiologists are more aggressive and they'll treat everybody, who has PVCs. But in general, I think we tend to focus on patients that have either severe symptoms or impairment of heart function.
The next question is, does AFib last for just seconds or minutes, or uh, do they last for like hours?
Yeah, so this is maybe a curiosity, right? How could it be that they could be so short or so long? So some people are in atrial fibrillation all the time, years and years. And so that we know that. And then yet there's some people who have atrial fibrillation very transient into seconds to minutes. So it's an amazing kind of condition. You can have that much variability, but it is true.
And next person says, when do you recommend cardioversion versus catheter ablation with
Mhm.
AFib and
Sure.
aflutter?
Sure. So cardioversion is the electrical shock to the heart. It generally is successful, meaning it generally works. Now, the problem is that the rhythm may come right back. So it's not a very necessarily a long lasting. So the purposes can be different, in other words, right? So we often use cardioversion because it works so quickly. But for the person that it comes right back, that's not very a long-term solution, right? We're not going to want to do cardioversion every couple of days. That's just not practical and ideal for the patient. So we're going to look for other solutions to prevent the heart rhythm. So medications and catheter ablation, I think, are the more likely considerations. On the other hand, there are patients that you do a single cardioversion and they last years. So for them, that might be a reasonable strategy. We just want to make sure we don't wait too long. However, as I mentioned, the data support earlier and earlier treatment, including catheter ablation, to prevent patients from being in it consistently.
Okay. Okay, two more questions. Uh, this one is about mitral valve prolapse. Can you give any advice about that? And because the person says now and then he or she notices that the irregular heartbeat that he or she has.
Yeah, so the heart has many heart valves to direct blood flow. The mitral valve is one of the major ones. Sometimes the valve kind of goes a little backwards away from its generally, and that's called prolapse. And so there are people that have this condition. And so there are different arrhythmias, both atrial and ventricular, that have been associated with mitral valve prolapse. But the treatment needs to be individualized for the patient. Many people don't need treatment and are pretty asymptomatic. So you just have to kind of understand what the rhythm is, do monitoring, understand, what the best kind of approach would be for the heart rhythm study.
Okay, thank you. And then the last question is it common for sleep apnea to cause palpitations? And if so, is it harmful?
Yeah, that's a great question. So, as I put on the slides, we think sleep apnea has many cardiovascular effects, and therefore should be treated. So, in general, we recommend treatment of sleep apnea, and there are probably positive effects on the heart rhythm overall. So, I think that's what we would say. Exactly the mechanism we don't understand. Some of it's because, in fact, probably the oxygenation to the body and the brain are not adequate. And so that probably contributes to many of the things that we see in terms of heart rhythm problems. But many of the things are probably much broader than that and affect the overall body and how our cardiovascular system works.
Okay, all right. Hey, thank you, Dr. Wang. You share so much information with us and those great slides, and you spent so much time answering uh, questions in the Q&A. So thank you. And I want to also thank our audience for joining us and all these great questions that you have submitted into this session. And if you would like additional information or resources, please go ahead and contact us at the Stanford Health Library. We hope that you'll join us for the next lecture, and thank you and good night to all.
Thank you very much.
Thank you, Dr. Wang.
Thank you.